Thank you for the invitation to speak. Thank you to ARI for having OCON in person and putting in place really important safeguards to make it a safe OCON in the midst of a pandemic. So most of you know who I am. I'm an infectious disease doctor. I work clinically doing critical care, emergency medicine, and infectious disease in Pittsburgh. About half of my time throughout the pandemic has been seeing patients. And the other work I do is policy in infectious disease at a high level. I work at a think tank where this is all I do. And it's a very strange thing when the very niche thing that you do becomes the biggest thing in the world. And that's sort of what I'm going to talk about here. What went wrong, what went right? But I mean, I think the real question, has anything gone right during this pandemic? And I'm going to try and, this is very cathartic to put together because so much has happened, and there's a lot I forgot happened, and there's a lot that really needs to be delved into in great detail. So hopefully I can get everything across to you. I talk fast, I know I talk fast, and I have a lot to tell you. So take it as that. I'm not trying to speed through, I just have so much to say. So obviously, just a couple disclosures because I do have a lot of affiliations and disclosures just so that you know all of that, it's there. So this is my agenda, and it's a little bit loose. Hopefully it flows. These are some of the topics I think are most important to understanding the pandemic and how it went the way it went. Where we are now and how we got there, what I think is the original sin of the pandemic, the initial response as it was and could have been, the false alternatives that we faced even today with the pandemic, being in the crosshairs of everyone when you're an infectious disease expert. I hope there are not any real crosshairs on me now, but I was told I didn't need security. And the solution, and then I think what's really important is what happens the next time, because this isn't the only time we're going to face that. So I'm going to talk a little bit about that. But my objective is to explain to you really why the pandemic unfolded the way it did. By now you've heard multiple explanations. We have really poor public health infrastructure. We don't have single-payer health care. All these types of inequities that exist in our society that people bring up. Some of these explanations have truth, but I don't think it's the fundamental cause. I think there's something deeper, and since I'm speaking to a philosophical audience, I think that will be something of interest to you. At least what I saw with my own eyes, taking care of patients and being in the policy realm, sitting on conference calls in Washington or being at meetings in Washington, thinking about how this was unfolding. And I think that sort of gives me a unique perspective because not only do I work on the policy angle of this, I actually see the patient. So I see what the policy does the next day when I'm back in Pittsburgh taking care of patients. So hopefully that gives you a unique insight. So just a little bit of COVID-19 101. Most of you know this. I should have just made this audience response questions. Remember, in mid to late December, a cluster of pneumonia cases without a diagnosis occurred in Wuhan, China. Initially, there was a report that it was linked to an animal, a seafood market. But if you look at the first case that they actually described in the initial paper, it occurred on December 1, which tells you that this had already been spreading in China in November. And that first case had no contact with the market. So the market it was a fish market, but it was, I'm going to use a really bad joke, it was a red herring. It was actually just a place where, it was just a place where they noticed all of that. And there was a major severity bias in the case-fatality ratio, which always happens because the sickest people are the ones you're going to notice first. So that really got people worried because we saw these high case-fatality rates. And then eventually we learned there was human-to-human spread. It took some time for China to actually admit that was happening because initially we thought this was initially they were saying this is an isolated spillover from a market, no human-to-human spread, so this is something more like Middle East respiratory syndrome or the first SARS. But once human-to-human spread was known, and that there was a spectrum of illness with people with very, very, very mild symptoms and people with very severe symptoms that were all contagious, this became something that was going to be uncontainable, meaning that it was going to cause a pandemic, regardless of what happened, just based on the biology and the epidemiology. They discovered a coronavirus, which they called SARS-CoV-2. It looked like it was stable in humans after a single introduction. I just put that slide there. That was a project that I worked on prior to this pandemic, where I talk a lot about what it takes to cause a pandemic and what types of characteristics you would expect. And if you Google this, I think you'll find a lot of background information that will help you understand why this virus was able to cause a pandemic. And it makes me look like a sage now, but that was something I wrote talking about what it is, the alchemy of a pandemic pathogen. And SARS-CoV-2 had all of that, primarily because human-to-human spread through the respiratory route with the spectrum of illness that was very very varied, with very mild cases being able to spread, meaning that you can go about your activities of daily living and still spread it to people. And it had an animal host. We know that coronaviruses all come from bats. So there was no way that this was going to be something that could be contained. So that meant from the very beginning we had to change the entire stance, and many people did not. Now we know, just quickly to talk about some of these other cases, that there was a large outbreak of flu in Hubei province, where Wuhan was. So this was mixed into flu cases in China at that time. The first case that they've actually documented was November 17th. We know that there have been cases in France in late December, and people who worked at the airport or whose spouse worked at the airport. They found it in the sewage in early December in Italy. Oropharyngeal swabs in Italy in December, even an anonymous skin sample in Italy in late 2019. What that tells you is that this virus, by the time we noticed it, it had already spread out of China. It was not going to be contained. So a lot of the restrictions you saw, travel restrictions, putting people on Air Force bases when they came back, were going to make no difference because the virus was already on the other side of those fences. That's one of the lessons from the pandemic, and we've always say this, that travel restrictions don't work when you're talking about a virus that spreads that quickly, and it distracts people. And I'm going to have quotes interspersed about some of these, how people were distracted or what they were actually trying to tell you when many of us experts were saying this was already not contained. I know people were going to ask me about the lab leak hypothesis. You can ask me a lot more in the Q&A. Just at the first cut, I'll tell you that the lab leak versus the natural spillover are both plausible. It's very hard to know because we have no Chinese transparency right now. I do not think there's any evidence that this was an engineered virus or a biological weapon. And this was clearly spreading in November 2019. And just a couple of days ago, the Office of the Director of National Intelligence released the unclassified report. And just to highlight some of the statements they made here, they said China's cooperation most likely would be needed to reach a conclusive assessment. That's definitely true. Beijing, however, continues to hinder the global investigation, resist sharing information, and blame other countries, including the United States. And this is really important. China's government's own uncertainty about where an investigation could lead, that's something very interesting. They don't quite want to know the answer because if it was a lab leak, and you can imagine if you're a laboratory worker and there was an accident there, it's not going to be met with, kind of a no-fault type of disclosure that, yes, we had a mistake here. They're probably going to be executed. So this is going to be very difficult to actually get to the bottom of. So let's just rewind back to around the first case that was recognized in the United States. There likely were more before this, but on January 22nd, President Trump said, we have it totally under control. It's one person coming in from China, and we have it under control. It's just going to be fine. And we know it wasn't just fine. We know we never had it under control, and it wasn't just one person. This was already spreading by the time they actually noticed it. And this is what's happened. And notice I have hospitalizations there. I've been somebody that's always been keyed on hospitalizations, not cases, because this is not a disease that can be eradicated or eliminated. What we're trying to do is tame it, make it more like other respiratory viruses. And this is where we are now. I downloaded this last night. And you can see we're almost to that horrendous peak. For any of you who worked in the hospital, it was not fun in December and January, and we're getting there. Now it's more regional, though. It's not the entire United States that gets hit. It's basically south of the Mason-Dixon line is where the problem is. So what would it have taken to get it under control? This is probably like a 6-week course in itself. Number one is a proactive approach. Thinking about the fact that this was a non-containable respiratory virus, that it was going to spread, and actually meeting cases as they came in, with testing, tracing, isolating. And I know that those of you who listen to your own show hear him say that all the time. It's actually true. It is the textbook way to actually deal with this, to meet cases as they come, and to protect the vulnerable. Because by the time we knew that this was already what we saw in China, that there was this spectrum of illness, that the older you were, the more likely you were to get severe disease. And we have nursing homes that were basically kindling, basically just waiting for that virus to come there and rip through them. But we did the opposite. We didn't actually fortify nursing homes. We actually sent contagious patients there. Governor Cuomo, my own governor, Governor Wolf, Governor Murphy in New Jersey, all just said if the hospitals, if these people don't need hospital care, just go to the nursing home. Nursing homes can't refuse. And they actually exploded in nursing homes. Sometimes in Pennsylvania, 67% of all deaths were nursing home deaths. The pandemic would have been looked a lot different if the nursing homes would have been protected. In the Pittsburgh suburbs where I live, one nursing home person gave hydroxychloroquine to everybody because it was totally futile. It was just a lot of bad stuff happening in nursing homes, and it's happening again in nursing homes now. The exemplar I've always said from the very beginning is Taiwan. Taiwan is, this small country that has the most robust public health infrastructure system that I've seen in terms of dealing with infectious diseases. They're not part of the WHO, not because of something they did wrong, but because China bans them from being in the WHO. And as part of a team, back in 2013, I spent a week in Taiwan just evaluating their ability to look at how they respond to infectious diseases and how they approach the problem. And I would say, let me just get these slides, are being weird. Okay. I would say that they're off the scale in terms of how ready they were. And they were ready in November, already talking about the fact that they were hearing rumors about something going on in China. And they don't trust China, obviously, for obvious reasons. So they jumped into action very, very quickly. At the very beginning part of the pandemic, Taiwan basically did not have to do lockdowns. They shut schools for about 2 weeks just to get things sorted out. And they had like 6 deaths when we had over 500,000 deaths. They've seen an upswing lately because they've had difficulty getting vaccine into people's arms there. Why have they gotten difficulty getting vaccines into people's arms, you might ask? It's because China is blocking their access to vaccines. China is also giving vaccines to countries all around the world, but one of the strings attached is you de-recognize Taiwan. So this is just, I think Taiwan needs to be in the World Health Organization. Taiwan needs to be the kind of the shining pandemic city on the hill. We've done so much better. In 2009, if you remember, there was a pandemic with H1N1, and people forget that it was a pandemic because it was all calibrated to the severity of illness, and we there were some mistakes and missteps that happened, but we did a much, much better job because things were done with the CDC in the driver's seat. And I would say that the CDC here, and some of you may have issues with the CDC, but we'll talk about that, but the CDC in this situation wasn't in the driver's seat. They were bound and gagged and in the trunk, basically, with somebody else driving with the CDC label on the car. They were not able to do what they usually do. They were way off of their playbook, and they had so much politics injected into them during the Trump administration, and that same politicization occurs now in the Biden administration. So these are just some of the things that I think could have been done, and we were all advocating that vocally, but kind of falling on deaf ears. So, to me, the original sin of the pandemic is the ability to test. So by March 1, China was testing millions of people a week. South Korea had tested 65,000. How many do you think the United States tested by March 1? It's not zero. Somebody has a zero. It's not zero. No, it was 459. What do you expect? But we were told anybody that wants a test can get a test. Here at OCON, anybody that wants a test can get a test. But not back then. And I was a doctor taking care of patients saying, I need a test. Like, you can't get a test on this patient. Because we had really fouled up a lot. First of all, there was a botched, first of all, there was this idea that this was only something coming from China. So who could you test for COVID-19? Only those people that had an epidemiological link to China, to Wuhan specifically, who came back within 14 days and had lower respiratory tract infection, meaning they had evidence of pneumonia. So what if you had a sore throat? Could you test that person? No, you could not. I tried to test them. You couldn't. It just was not allowed. They used a botched testing kit from the CDC. And I cannot figure out why the CDC did not use the WHO test or a South Korean test. They decided to use their own test, and there was difficulties with the controls on the test. Then they said, this test, the FDA said to the CDC, you basically cannot market this test. You can't give it to anybody. It can only be done at the CDC. So they had to make the CDC go through that whole FDA process to authorize it, and then it could only go to state health labs. So the turnaround, so there was maybe 50 or so labs that could do it in the country. We had undocumented spread, uncontrolled spread, and there was just no way to get around it. And the other thing is that they tied the hands of laboratories like Quest, like LabCorp, like the university labs that make their own tests all the time. They were unable to do that because, paradoxically, when you declare a public health emergency, it removes one of the ways that you can actually get tests into people's hands. And they knew it. People like Scott Gottlieb, the former FDA commissioner, saying, if you declare this, you're going to have to fix this because it's going to happen. And then it happened. And it took them a long time to actually fix it because there was this idea that testing was something that was just going to happen organically, that there weren't obstacles there. And that quote from President Trump, I think, tells you that they think that this is not something that they were going to consider part of their responsibility, because really there was anathema to actually finding cases. And in the pre-vaccine era, cases were very important because cases translate inevitably into hospitalizations and deaths, so you needed to know who was sick. But they didn't want to do testing. They didn't want to know. There was major blocks on home tests. The tests that we're using here, those are home tests. That was something that was not on the table during the Trump administration. They did not want them to be approved by the FDA. And actually, one of the platforms in President Biden's plan was home tests. I think we still have problems with home tests. They should be in vending machines. They should be everywhere. But at least we have them. And that was a major, major issue because we were unable to know who was infected and who wasn't. And there were individuals, for example, in Seattle, a woman named Helen Chu, who was doing what was called the Seattle flu study, where she wanted to go back and say, let me look at these flu samples that are flu negatives and just see, is COVID-19 there? And the government shut her down. The state government said, no, you didn't consent people for COVID-19. So that data basically was not accessible, even though we could have figured out what was going on. And she did show that there was community transmission going on in the Seattle area when everybody was saying this is just a China problem. So you can see, there's a lot of great headlines and a lot of great journalism really looking at how this all unfolded. I mean, but then there's even this type of stuff, which is really, to me, mind-boggling. That the federal government was confiscating when states said, so Larry Hogan, the governor of Maryland, buys tests from South Korea or wherever, then he's worried about them. He's using his National Guard to protect them from federal agents that will take them. And the federal agents were taking tests. Federal agents were taking personal protective equipment that states were doing because there was a major failure at the federal level. This is things that were never in anybody's playbook, that you were going to see this type of thing, that the National Guard basically facing off with federal troops hiding tests so the federal government wouldn't take them from state governments. So what we were was blind. We were blind. January, February, March, we had no way to know who was infected, who wasn't. We didn't know how they were getting it. And what that did was set off chains of undocumented transmission that were spilling into hospitals. All of that precision-guided public health that we talk about, we could not do because we were completely blind. And I think that's what led to all of the stuff we saw in March and April, because governors panicked. They had no idea what to do. There was no way to get tests. The federal government had failed. So they just basically, and I'm going to talk a little bit about what was going on in their minds, but they had no real solution other than what they did. And they obviously went one way, because they used a blunt tool because a blunt tool would work, and that's what they wanted to do. And what that did is set up tons of false alternatives. In-person schooling versus distance learning, how to one-size-fits-all things, where people weren't thinking about what's sustainable, what isn't sustainable, what are the deleterious cascading effects on other problems. None of that was in people's minds because we were stuck in this false alternative where either you do nothing and people die, or you lock everybody down and nobody dies, but all the other nobody dies from COVID, but all the other bad stuff happens. That it's the economy versus lives, not realizing that the economy is people's lives. All of that played out. And I sometimes think about it this way, it's like either Mardi Gras or it's lockdown, and that's basically what was offered to us. And that's how the whole country kind of did not form the ability to risk calculate. So there was no way to know what was driving transmission, but we knew not all activities are equal. We knew early on that outdoor activities were less likely to spread than indoor activities, but that wasn't something that people wanted to think about. They really took an abstinence-only abstinence-only approach. So abstinence-only is something from public health where it comes from sexually transmitted infections and from HIV, where you say, never do this, there's no way to reduce the risk, just don't do it. Not wear a condom, not get a test, not take PrEP, not do all of those types of measures that actually end up decreasing transmission and work, they are called harm reduction. And we basically threw harm reduction out the window and went to an abstinence-only approach. And what that did is basically stunt the ability of anybody to risk calculate because no one knew what was safe, what wasn't safe. And places where they went abstinence only, like California, for example, they said no outdoor dining. Even though outdoor dining is not going to cause a major transmission risk, that drove people underground. So, okay, we can't go sit outside and eat, so just come over to our house and we'll all sit on the couch and watch the Super Bowl or whatever it might be. That's way more risky than just having an outdoor TV at an outdoor bar and sitting there. That type of approach was something that was anathema to them early on. Only later, and it was driven by the HIV part of the infectious disease community, did they start saying, we have to think about harm reduction. I wrote a Washington Post op-ed talking about risk calculation and harm reduction in the summer, And I was just castigated and ostracized that you can't do this. I said, well, people are going to take risks. People have values they want to pursue. They may willingly accept that risk. Let's give them tools to make it easier. Do it outside. Wear a mask. Open a window. That type of thing. That was something that just was thrown out. I just still don't understand why they went to this abstinence-only approach. But that's part of the problem we have now when people don't understand that, first of all, that this is never going away, and they have to learn how to risk calculate. I think comes back to the fact that the abstinence-only approach was used so uniformly that no one was able to risk calculate. So you've got one group of people that are very scared of minute risks, then you have other people who act as if there's not a pandemic, and I think that's directly the result of this. So how policymakers think, I think, is another thing that I wanted to emphasize, and I think most of you probably will find these funny, but it's actually true when you have to deal with them. They're very short range. Just how long they're till their next election cycle. They're unprincipled, whatever works. They just need it off of the table. They need some kind of answer. The timeline, like I said, is the next election. That's all they care about. The question they ask themselves is not, how do I fix this? How do I stay in power? They don't want to be blamed. That's why they're so risk averse. And to them, the long term doesn't matter. So that makes it very hard when you're an expert trying to deal with this, because you've got to translate all this knowledge to these people, and they're a whole different species. And that's one of the things I learned the most, is no matter how good you are as a subject matter expert, no matter how much you've prepared and prepped and done stuff, it's these people at the end that have to execute it, and that's part of the failure. Just some more quotes here. So what did people learn? They saw what worked in China. A massive lockdown where people were actually nailed into their houses. You can look at this quote from February 7th from President Trump. Just had a long and very good conversation by phone with President Xi of China. He is strong, sharp, and powerfully focused on leading the counterattack on the coronavirus. He will be successful, especially as the weather warms, all that. So great discipline is taking place in China, and President Xi strongly leads what will be a very successful operation. So that's the lesson they took, that worked in China. Let's try that here. Another one. We have it very much under control in this country. It's a big situation going on throughout the world. We very much closed our doors in certain areas. Remember, that was already here. It didn't matter. And we'll see what happens. I knew what was going to happen. We have it very much under control. Very interesting. We've had no deaths. We've had a great practice. We had 12 at one point. Now they're gotten very much better. Many of them are fully recovered. But then again, I think President Xi is working very, very hard. I spoke to him. He's working very hard. I think he's doing a very good job. It's a big problem, but President Xi loves his country. So that's the lesson that was being drawn. That this worked in China, let's try this here. And they didn't think about any of the cascading impacts. Who is essential? Who is not essential? That was what governors were deciding. This is an essential job. This is not an essential job. But everyone's job is essential because you have to work. If nobody produces the stuff, I think Elon Musk said that there's no stuff. And I think that they didn't understand that. They had this myth, we're stopping elective surgeries. That's not breast implants. That's aortic valve surgeries. That's colonoscopies. That's all kinds of things that are scheduled with some flexibility, but not infinite flexibility. All of medical care got disrupted. Substance abuse, psychiatric care, childhood vaccination, alcohol. So that it's not surprising that alcohol and drug consumption increased. Everything was totally in disarray because no one wanted to think about the cascading impacts because they're only thinking about the short term. And that's the story of the early days of the pandemic, of how this all happened. But it would be one thing if it happened in March, April, May. But we basically rinsed and repeat again and again and again. So so in the summer, things started opening back up, and people started getting infected. And then the governors are all scratching their heads. Well, why is this happening? Why do you think it's not? Why do you think it's happening? Did you do anything? Did you get testing? Did you hire contact tracers? Did you think anything happened differently with the virus? I don't know how that happened again. And they just didn't want to make that decision. They just didn't want to hire people. They didn't want to actually put in place the public health infrastructure. So what did you expect was going to happen in the summer? So you think they could never do that again. Just fast forward to Thanksgiving, Christmas, they did the exact same thing again. And we had the biggest peak that we ever had. And we told them it's going to get worse when it gets colder because of the virus's capability. Get contact tracers, get testing. None of that happened. That's this cycle. I'm going to talk a little bit about that towards the end, about this cycle, how really mind-boggling it is. one of the things that's important to remember is hospital capacity, because that's something that's almost fixed in this country because of our healthcare system, because competitors can say you can't open new beds, because they have to file certificates of need to say you need new beds. And I think it's just important to remember that's what flattening the curve was really about, was trying to spread this out so our hospitals didn't go into crisis. Because hospitals are in this kind of hotel model. An empty bed means no revenue, so they don't want to have empty beds. So they've been shrinking beds, and there's been a big trend to move things outpatients. And I think that's a major problem that we have that made us very vulnerable to these hospitals going into crisis, like they are going into crisis right now in parts of this state, in Louisiana, in Arkansas, in Florida. And I think that the other part of this was that we have very bad public health infrastructure. And I think that's because public health has kind of morphed from its original mission. This was something that was about communicable diseases and controlling communicable diseases, saying, this person has plague, they're contagious, this is what they need to do, this person has smallpox, but now they do lots of things. They go, in Pittsburgh, one of the big things is to go after U.S. Steel and pollution, and they got and obesity, and all of these things which are really sexy to policymakers, but they're not core functions of public health. I mean, how often do you see like a mayor say, we have the lowest gonorrhea cases in the tri-state area? They never say that. But it's those people who stop those gonorrhea cases, who stop those congenital syphilis cases, who they're the same ones that do the contact tracing. They're the ones who do all of the day-to-day work that was necessary during COVID, but they're not prioritized, they're not valued, they've been under-resourced forever, and no one wants to talk about it. And I think that's really important. And then it's also a major bureaucratic process. Try to get hired by a county government. If you're a contact tracer, that takes you that's more than like a CIA clearance, I think, sometimes to get hired by the county government. How many forms you've got to fill out. So they just did not do anything to make that happen. And I think this is something we have to fix for the next one, that this hospital capacity issue and the fact that when the core functions of public health, the ones that they actually are really, part of the defense of individual rights, that you don't have the ability to infect other people, or you don't have the right to infect other people, that whole part of it needs to really be refocused. So just a little bit on the crosshairs. So because politics got injected into this, it was very hard, it's still very hard today, to not get people's ire. And I've never seen experts get attacked so much. And I think it's because of the role that many of us got put in, not by our own doing, but because of that species of person called policymakers that we had to deal with, and politicians. And I think it was, people having to get security, death threats. I can't tell you how many nasty emails I get every day from people. And I made a very conscious choice that I was going to, because we live in a tribal world, to go on Fox, to go on CNN, to go on MSNBC, to go on any network that actually asked me. But I wanted to make sure I turned down deals from both Fox and MSNBC, because those were two, I thought, tribal networks, and that was going to make my message get diluted on either side of it. But it still puts you in the crosshairs. And I think it's because something that I'm going to talk about a little bit later, about what I think was the fundamental cause here. But at least me being on TV, I can just show you something funny here. So that print got a lot of press all over the country, all over the world. But you can see, so that's the room raider guy who writes everybody's Skype thing. And you can see that people, I get a lot of stuff for that Atlas Shrugged print, not down with the Atlas Shrugged print. Or people can't imagine that I'm a person who likes vaccines but likes Atlas Shrugged just because of the caricatures in our culture. So the other thing that happened with experts and being in the crosshairs, I'm just going to show you a couple quotes. So Nancy Messonnier was the director of the National Center for Infectious and Respiratory Disease at CDC. She was the lead person in February. So as more and more countries experience community spread, successful containment becomes harder and harder. We expect we will see community spread. It's not so much a question of if this will happen, it's when. You did not see Nancy Messonnier after she made that statement. She basically disappeared. Now she left the CDC. The same day, President Trump said, I don't think it's inevitable. It will be a very small lever, it could be a larger level. Whatever happens, we're totally prepared. It may get bigger, it may get a little bigger, it may not get bigger at all. I don't know how useful that is. We'll see what happens, but regardless of what happens, we're totally prepared. When you have 15 people, and the 15 within a couple of days is going to be down to close to zero, that's a pretty good job we've done. I just leave that one there. So that's what was going on. And what happened was there was a major breach. And this is something that's unforgivable, because as an infectious disease doctor, as a person who works in public health, there's a sacred trust between what I tell someone I think is the right policy, or what I think is going to happen, what I advise them on their health, what I advise them, the country, or on an outbreak, that people trust what I'm saying is true, or that I'm doing my best to come up with that. And I think what they've created now is such a breach between public health and infectious disease and the general public that no one's ever going to believe us again. They've split our whole field in half. People aren't speaking to each other. People are leaving the field because we got put in this odd position. And I think one of the anecdotes I just heard a couple of weeks ago was like a major person at CDC wants to quit and work at a bookstore. That's what's happening. The best minds are kind of going on strike in this field not because we're not appreciated, but because we got put in this position where we were having to make all of these decisions the policymakers abdicated on. And I think that's something that we're never going to live down. The fact that now the general public doubts what the CDC says, or doubts what an infectious disease doctor says, or calls me a liar, or calls me a pharma shill one day, calls me something else the other day. It's really, really toxic out there. And I think it's important to remember what the role of experts are. We brief, we inform, we're very task-focused. They ask us what's going to happen, or what do you do here? This is what we'll see. And often I would say, this is what's going to happen, this is what we'll see. And I got criticized because I wasn't criticizing the policy, but I was really trying to be a commentator on what was going on, what was going to happen next. And remember, the CDC was bound and gagged. And they're the real experts. They're the ones who drive the policy with expertise. But they were not able to do anything, and they're still not able to act as they would in any other pandemic. And like I said, I had so many love letters. If children would watch, I couldn't put them on the screen because you'd have to like black them out, how bad it was, how bad they are. So I wanted to this is a weird little thing that occurred to me. So I was thinking about what happened. People ask me, why did Dr. Fauci do this? Or what did he say this for? And I was remembering this movie from the late 1990s called The Siege. And it's a movie about a terrorist attack that happens in New York City. And Denzel Washington and Bruce Willis are in it. And Bruce Willis is this big general. And they say, we need to actually bring the military in and handle this problem because we've got a terrorist on the loose, and your task is to find this terrorist. And this is just a quote from General Devereaux in this movie. The army is a broad sword, not a scalpel. Trust me, Senator, you do not want the army in an American city. And he also says, make no mistake, we will hunt down the enemy, we will find the enemy, we will kill the enemy. No card-carrying member of the ACLU is more dead set against it than I am, which is why I urge you, I implore you, do not consider this as an option. And many experts in my field were tasked with just stop COVID, get the cases down, do whatever it takes. And I can tell people what to do if that's your goal, to get COVID down to zero and take out of mind what happens to heart attacks, what happens to childhood vaccinations, what happens to people's jobs, what happens to the economy. And I think that's the best explanation that I have in my mind of how those people in my field came to view this, that they were given one task and that's what they were going to do. And the policymakers didn't set the bounds. They're the ones who have to weigh the cascading impacts. They did not. They abdicated. So we were left with these broad tools. And what made it worse was pandering from the Republicans, from the Democrats, all pandering to their own constituencies, which made it so hard to be able to get through to things. So for example, school openings. We were trying so hard to do school openings last year, but the teachers' unions were standing in the way of it. And the teachers' unions were contributing to the Biden campaign. They were the biggest obstacle, even when we had data to show that it was happening. And then you have it on the other side, with Republicans, for example, making it illegal to be safe in certain places. So if you're a cruise ship and you want to dock in Florida, and you say, we want all our passengers to be vaccinated, you have the governor of Florida saying, that's illegal, you can't do that in this state. You have so much of this going on that it makes it so hard to actually do what's right. And then legitimately, people in the general public have no idea what to believe, what not to believe. But this, I think, is another, I guess, side effect of the political system we live in with these pressure groups that when the government actually has to do something, they're unable to do it because they're so worried about those things I talked about before, staying in power and pandering to their constituents. But we did have a hope, and I think the hope was the vaccine. And I have a lot to say about the vaccine, but one of the things that's really important is that we use vaccine platforms. And I spent a lot of time before the pandemic advocating for vaccine platforms because they can really speed the time of development of a clinical candidate. And vaccination is always the best way to deal with an infectious disease problem because if you can prevent something from occurring, Then you don't have to worry about all the negative effects that happen, the treatment, the hospitalization. And when you look at a pandemic, the time to develop vaccines was thought to be the rate-limiting step. We never thought it would be getting vaccines into people's arms. We thought it would actually be developing of vaccines. So vaccine platform technologies emerged as a solution. We have had treatments, and I just want to talk a little bit. So dexamethasone is a very, very cheap steroid that we use in hospitalized patients. That's been the mainstay of how we've decreased mortality, why we've gotten people better faster. We've been using antibody treatments as well, like the Regeneron antibody treatment. Some of you might have gotten it. But we had this huge distraction with the hydroxychloroquine and ivermectin debacle, which still goes on to this day. There are prisons in Arkansas that are not vaccinating prisoners, but giving them ivermectin. This is just, that's another thing that you can ask me about in the question period, but it's another distraction that we've had throughout the pandemic. And the real treatments that we've worked on have been kind of forgotten. People don't think about, they always say, you know, the pharmaceutical companies want some very expensive drug to sell to people, but they forget that dexamethasone is the one we use the most and it's cheap and generic. I think there's a lot to be said there. But the vaccines have really been the major promise that we've seen with controlling this pandemic with our own eyes. And I saw it immediately after people got vaccinated. And what they do is they are really important when it comes to reducing the impact of the pandemic by taking pressure off hospital capacity. There's ways to think about how to use the vaccine. Should you be giving it to older people first? Should you be giving it to people who spread it? Because 80% of cases are caused by 20% of people because it's very heterogeneous how spread is. There's a lot of debate, but what we did in the United States was prioritize hospital capacity. That's why our priority group 1A was nursing home patients. Remember, 67% of deaths in Pennsylvania, nursing home patients. So when you make a vaccine in the past, and I've given some lectures on this, you usually try to figure out what the target is for the immune system, some specific protein, and then you try and deactivate the virus to give your immune system something that looks like it. And it can be a long process. It takes years. The fastest vaccine in the past was 4 years with the mumps virus. That's not, if we didn't have the vaccine now, we wouldn't be having this conference. But what Operation, so Operation Warp Speed was something that harnessed the ability to actually manufacture ahead of knowing whether it was going to work. That was something that was novel because most companies are not going to get into something like this unless they know that they've got some indication that it's going to work. They're not going to make hundreds of millions of doses. And it was a portfolio approach where they invested in many different vaccines and vaccine technologies, really focused on platforms because they could kind of plug and play and move with them. And I think that was probably the biggest success of the pandemic was Operation Warp Speed. Paradoxically done by the Trump administration, many of whose supporters won't get vaccinated, even despite his pleas for them to get vaccinated. But this was really something that I think was the government working efficiently to do it. But I think there's important caveats to it. The first vaccine we had, the first vaccine that was approved, fully approved a couple of weeks ago, was Pfizer's vaccine, and they did not take any Operation Warp Speed money up front. They said, we'll sell it to the government, we'll have a pre-purchase agreement, but we don't want any development money, because they wanted it to all go to their pocket. And I think their CEO has made some interesting comments. They wanted to liberate our scientists from any bureaucracy, and they also said, when you get money from someone, that always comes with strings. I wanted to keep Pfizer out of politics, by the way. And obviously Pfizer is in politics now because the emergency use approval came a couple of days after the election. But Pfizer was one of the exceptions to Operation Warp Speed. But I do think that this was probably the shining success in the pandemic was the fact that we had a vaccine and now you can get a vaccine anywhere, not in 4 years, but within a very rapid amount of time, harnessing vaccine platform technologies. But I think it's also important to remember what we want from a vaccine. Remember, vaccines are not force fields. They're not bug zappers. They're meant to decrease the severity of infection. So when you hear about breakthrough infections, if they're mild, that's something to cheer for. That means the vaccine's working. It's much better to get COVID post-vaccine than it is to get it pre-vaccine. And remember, this isn't going anywhere. So it may be a point that every one of us here gets a breakthrough infection post-vaccine. But it's going to be mild because we were vaccinated. Or maybe it will be mild because we had prior immunity. I know people have questions about that. You can ask me in the Q&A. But there's kind of a gradation. And to me, what's really important about a vaccine, and you can ask me about boosters in the question period, is their ability to prevent severe disease, hospitalization, and death. That's what we're trying to do here. So that's what the success of a vaccine is. And I think these vaccine platforms like mRNA vaccines have done really, really well. And I think that this was something we recognized would be a way to change the way you get involved in emerging infectious diseases, because companies don't want to get involved in something that's rare, that may never happen, it's going to happen in some part of the world that people can't pay for. But platform technologies allow them to leverage, for example, mRNA technology that they might be using for cancer vaccines on an emerging infectious disease, because it's the same technology, it's not a huge cost, they have economies of scale. So I wrote a report there on vaccine platforms before there, and that's my vaccination shot when I got that. That was very surreal to be breaking news when I got my vaccine on December 13th. You can date it by just how many deaths there were. It's half of the deaths that we have now. But we were talking about mRNA vaccines even before this, so this didn't come out of left field. This was something many of us in biosecurity, in pandemic preparedness, had said this is going to change the way we think about infectious diseases, and Moderna and BioNTech really rose to the occasion. I remember being in meetings with Moderna when they were just really a no-name company that they didn't think, nobody thought they could do it, where I was in rooms with other major pharmaceutical companies who just didn't think it was going to happen. But I think that was a huge success, and I think a lot of us were really happy to see these vaccines come to fruition, because it will change the way we deal with infectious diseases in the future. So I think that this is the part where I try to dabble a little bit into philosophy to try and understand what was happening here. And to me, the biggest explanation, and I saw it with my own eyes, was evasion. So everybody knows what evasion is in this crowd. We've had multiple talks about it. It's come up in multiple lectures even before me. But just imagine if you went to some refugee camp and you came back and you had fevers and you had night sweat, you're coughing up blood, but you don't know what it is. You just ignore it. And it's really tuberculosis. That's what happened on a scale for the whole country. And I just wanted to delve into, this is kind of my own kind of thinking on paper or thinking out loud about what I think happened. So, evasion is an active process. You've got to work not to see something that you think is unpleasant, something you don't want to be real. It's very different than what a scientist does. So when we saw that there was pre-symptomatic transmission, we completely changed on a dime on masks, because we saw the data. We didn't evade that. Initially, we were thinking, maybe it's not true, we want to see more studies, but once more and more of those studies came out, it became clear to us that we accepted that fact. We didn't evade it. That's why a lot of us who had not necessarily advocated masks for asymptomatic people, including myself, changed, because the data changed. But it's completely the opposite of what was going on politically. People were not acting like Taiwan. They were acting very differently, and they continue to evade today. So I just did some little Googling or looking at Merriam-Webster, just to not give you kind of a boilerplate objectivist definition, but it means to elude by dexterity or stratagem. That's the Merriam-Webster definition. And I think that's good. And some other synonyms: dodge, escape. And we think about evasion just in our general life. When you take the oath of office for something, you do it without any mental reservation or purpose of evasion. But that's not what our politicians did. The whole thing was an evasion. And now some quotes that you might be familiar with. They believe that reality can be altered by the power of the words they do not enter. It's not a pandemic. We're not going to have a bad outcome. We've got this under control, or that a thing will not exist only if you refuse to identify it. I mean, that clearly was going on in the early days of the pandemic. But remember, reality is not to be wiped out. It will merely wipe out the wiper. And it wiped out the wiper, and it wiped out over 600,000 Americans. So evasion kills. And that became very crystal clear to me. It's something you read about, and you read it in these essays, and you read about it in novels, but actually seeing it up front with my own eyes, where people were just evading what was happening, just refusing not to think, just to try to make it better, or just always trying to play it down. That has real consequences. And I think that, to me, is really the underlying cause of what happened during this pandemic. Why it ended the way it did, why we're still in it. Because we don't have people who actually are able to think. Yesterday, Dr. Smith talked about some other words: disintegration, fragmentation, embargo with the evasion. That's completely describes what was happening in this pandemic. There were certain facts that were embargoed. We weren't going to announce them. Everything was fragmented and everything was disintegrated, and I think that's why we're in the situation that we're in. Early on in the pandemic, I kept thinking about the Taggart Tunnel disaster because I could see it coming, and I think this is the best parallel that I can think of. The US was the most prepared country. We had the best toolbox, the best experts. We wrote the book on it. My think tank did multiple tabletop exercises with the highest levels of government, and we sailed through it every time. It was just that we didn't use the toolbox. For example, in the Taggart Tunnel disaster, there's that spare diesel that's supposed to be there. We had 100 spare diesels. They're still sitting there, those spare diesels. No one wanted to use them. And I think that the tunnel disaster is worse. Not only did the people that died want to live, unlike the ones in the novel, we went through the tunnel, then reverse went back through it, we went back through it again, went back through it again. And I just some parallels. I thought, what happened in this pandemic is deeper than politics. I think it's the philosophical outlook of those individuals who were in charge of making our decisions. So it's much deeper than politics. It has to deal with their epistemology, how they face facts. They did not have an unswerving commitment to facts, no matter how unpleasant. That was something that was discounted. That's why people at the CDC are quitting. That's why people at the CDC were not able to speak. That's why Dr. Fauci had to have everything he said cleared by the White House. In a real pandemic response, the whims of a powerful politician wouldn't warrant consideration above the facts. But that's exactly what happened through much of this pandemic, that we were trying to massage things so that any politician on either side, a Democrat governor, a Republican governor, the President Trump, President Biden, that we're trying to make it fit their narrative, fit their political agenda, not actually fit the task at hand. And I think this quote from Onkar Ghatel's essay is really good. In a world which teaches people that the only absolute is the cries and wishes of men in power, that the way to get people to act is through fear, and that men do not live by reason, in such a world, what else is to be expected? And I think that's the deepest explanation. That's why the Taggart transcontinental disaster is the best parallel in my mind for what happened during the pandemic. But the thing is, it's not going away. There's going to be a next time. And I think we have to get this right. We have to be proactive. We have to have at-home diagnostics in people's hands. We have to remove all of those barriers. We have to advance vaccine platforms. Because it's not a question of when the next pandemic, it's not a question of if, it's when. And there are many other viruses, many other threats that we face. And we have to start working, looking at viral families that have pandemic pathogens within them, trying to be proactive. That's another report I wrote on at-home diagnostic testing. I think that we have to really just change the way we do this so that this never happens again. The cost is so high in terms of hundreds of thousands of lives of Americans, trillions of dollars of wealth. And I think that this is something that we have to demand a solution to. This pandemic was not a failure of experts, not a failure of science. It was a failure of the federal government, failure of the state government, failure of the local government, failure of your school districts. And I think we have to hold people accountable. I don't think that we can sit by and just hope that this doesn't happen, or that we get lucky like we did with H1N1 in 2009. And I think that I applaud ARI for putting effort into coming up with a pro-freedom approach to infectious disease, this white paper, which I urge everybody to read, because I do think it articulates a way to think about this, one that's sorely needed in Washington. And I hope that is something that we see codified into law. And I do think we have an opportunity right now to get this right. I'm involved in multiple discussions right now in Washington trying to fix these problems, because they're listening for once. And I think that maybe we can get a little bit better next time. Because we know that experts can be jettisoned. We know that we have to get this codified. We know that it has to be something, there's a legal framework for it. That's how we get this right. So I'm coming to the close, and I left a lot of time for questions because I know I'm going to have probably more than I can answer. I'll leave you with a couple more quotes, and then I'll end. It's going to disappear. One day, it's like a miracle. It will disappear, and from our shores, it could get worse before it gets better. It could maybe go away. We'll see what happens. Nobody really knows. But we did know. I don't have to put who said that. And I don't have to put who said this either. to save the world is the simplest thing in the world. All one has to do is think. I think that, that's the closing line of OPAR, which we're here to celebrate. And I think that really fits because we were thinking. They just had to listen to us. So again, thank you. As one of my little collages at home of the 3 vaccines, the Ghostbusters, my favorite, saving the world from that dragon, which is COVID. That's And I just wanted to put some acknowledgements of people in this community that I've reached out to throughout the pandemic that have given me people to talk to listen to me, to run things by, because it's very hard to do this. And I also want to give the impression that, I'm still on the side of I'm on the same team as the CDC, even though I may correct them. That's a picture of me giving a lecture there. I still get chills when I walk in the hall, when I walk through that hall in Atlanta, just to be in the CDC. So I think that's part of this, is trying to defend the CDC to get this right. So again, thank you for that. Thank you for your applause, and I'm happy to take as many questions as I can.
So because I couldn't get enough of, disease on television, I watched the show The Last Ship. And in that show, there's a disease that's about as contagious as COVID, and it wipes out but it's much more deadly, and it wipes out like 90% of the population. Is a disease like that possible? And if so, what would happen if that struck us now, given our... Should I ever go outside again?
So these are hard questions to answer because there's often a trade-off between lethality and transmissibility. Because if a virus kills you, and especially if it kills you fast, it's not going to be able to efficiently spread because you're sick in bed. For example, Ebola has a very high case fatality ratio, but it can't spread very well because when you're sick, when you're most contagious, you're in a bed. So it spreads in hospitals and village healthcare centers. The only disease that actually does that is one that you've probably gotten accustomed to, was HIV in the pre-antiretroviral era. HIV was 100% fatal and contagious, but it didn't kill fast. That was the difference. But that's why it could spread, because there was this long latent period. I don't think a 90% fatal disease would be that transmissible. If you're interested, in 2016, I wrote a piece in The Atlantic about this. If you just Google it, about an extinction event and whether it's possible with infectious diseases. I don't think that you'd see that happen. I think it would probably be a lower. And I do think, so the case fatality ratio of COVID is probably around 0.6 or so is where I've kind of pegged it. I don't think we could even deal with a 1% fatality rate in this country, how bad we are at doing this. So there are things that are even scarier. Middle East respiratory syndrome, 30% case fatality rate. Bird flu, 60% case fatality ratios. And bird flu will come. Mark my words, that we will have a bird flu outbreak. And I think we are nowhere near prepared for that, because we can't even handle a 0.6.
What would that look like if there was a 60% fatality rate virus? Like, what would happen? If that's just a matter of time, then it would be a disaster.
It would be a disaster for hospital capacity. The hospitals would be crushed very quickly. It would be like I can't even imagine. It would be unfathomable to me what would happen at that level. We see these cases occur, but they don't transmit very well between humans yet. These bird flu viruses in China, they kill somebody and then they don't really necessarily move to anybody else. But there are changes that are occurring with that give them the ability for that we worry about sustained human-to-human spread. They haven't occurred yet, but I don't know what it would look like. Something like 1918 on steroids, probably. In 1918, it was 1 to 2% case fatality rate. I think it would be calamitous. But the thing is, we have all these solutions. We could pre-make vaccines. We have antivirals. We can think about hospital capacity. We can meet cases as they come, knowing we're going to get something. Like, I think in the United States, we would have had 50 to 100,000 deaths no matter what. I don't think that would have been, that was probably not going to be stoppable, even in the best case scenario. Probably, based on the way our policies are. But I think we can be proactive. We can get all of this in place ahead of time and actually think it's going to and act as if it is a real eventuality. We do this for other threats, nuclear war, all of these types of things. We're prepared for that. There's multiple plans. We just have to use them, and we have to be proactive. But people don't think about this. When these things go out of the headlines, these boom and bust cycles of funding and politicians prioritizing it, that evaporates. And I think you can't do that when you're talking about an ever-present threat. I always say, if you were an alien looking at Earth, you would say, this is a planet of bacteria, viruses, protozoa, fungi, and some other things. So they're going to come.
Thanks.
Amish, we have an online question that my colleague Nikos will be asking remotely. There you go, Nikos.
Hi, Amish. Hi, everyone. So the question is, you repeatedly said in your interviews that breakthrough infection after vaccination is not something unexpected. What is the breakthrough rate for COVID in comparison with other previous infectious diseases, such as polio, measles, smallpox, etc.?
So that's a good question. So each vaccine and each pathogen has its own idiosyncrasies. So our measles vaccines tend to have very high efficacy, so you don't see very high breakthrough infections, probably on the scale of much less than 1. So it's probably 1% or lower for COVID-19. At least that's the early data. It may change, but it's even lower than that for measles. Polio, it depends upon which vaccine you get. If you get the Salk vaccine, which is made in Pittsburgh, or the Sabin vaccine, one of them is meant to actually have you get one of them. They don't necessarily provide sterilizing immunity. They don't all do that. It depends on what the vaccine is. But the breakthrough rate in those are based upon the fact that they're trying to prevent severe disease. So with polio, it's less about preventing the mild infections of polio, but the paralytic polio. But the breakthrough infections occur less with those based on the technology in those vaccines. But we knew that this wasn't going to be something that was going to go away. Both measles and polio are technically eradicable diseases because they don't have animal hosts. So when you look at COVID-19, our goal had never been, with a respiratory virus that spreads efficiently, to erase all cases. It was always just to remove the ability for the virus to cause serious disease. So when you look at the breakthrough rates with different vaccines, it's like not really comparing apples to apples, because there's different goals with those vaccines, different features of those viruses, and different general trajectories of those outbreaks that you're trying to deal with. So I don't think it's a fair comparison. But breakthroughs were expected, and our goal, again, remember, flattening the curve, preserving hospital capacity. That's what these first-generation vaccines are doing. There may be a second-generation vaccine down the road that does something more like the measles vaccine, that maybe causes nasal immunity. That's probably the issue with breakthrough infections, that there's not enough antibodies in the nose, but not with these first-generation vaccines. So I think that they're succeeding off the scales, basically. Just walk through a hospital and see who's hospitalized.
Thank you.
In your vision of an ideal society, what role would the government play with regards to public health infrastructure and dealing with pandemics?
So there's two major areas. One is the fact that when you are infectious with something, you don't have the right to go infect other people. So the government has a right to prevent you from infecting other people by being able to quarantine you or isolate you or give you guidance on how to do that to make sure that you're not a threat to other people. That's the original role of public health. That's what it was started for smallpox, for plague, for communicable diseases. The other area is when it comes to public health preparedness for biological weapons and biological warfare, because there's a lot of crossover between those pandemic preparedness stuff as well as with biological weapons. But that whole part of that preparing for them, developing countermeasures against those, for the military, for example, and for the civilian population, as well as being able to set up a way to detect these types of attacks when they occur. And remember, the Soviet biological weapons program was the most extensive weapons program that ever existed, which was unbeknownst to most of the US intelligence until they actually defected and told people. That's where I find the most core, the places where I think where the legitimate function of government would be in public health.
Thank you.
Hi, Dr. Adalja. I just want to let you know that I've been following you for over a year now, and you've kept me sane, and I want to thank you, and you've been a real hero to me.
Thank you.
And speaking of heroes, I want to mention the lady and the gentleman who brought mRNA to us, Kathleen Carrico and Drew Weissman. And I just wanted to perhaps ask you a little bit more about mRNA, how it works, and I know that there have been a lot of conspiracy theories around it, and maybe you can address those. And I really do hope that Kariko and Weissman get the Nobel Prize or some kind of award, because it's just amazing what they have done. Thank you.
All right, so this is a lecture in itself, but I'll try to be brief. So, so mRNA, that's the part of it's genetic material that's used to make proteins. Our bodies make mRNA all the time. You've got lots of mRNA in your body. What the idea is to make a synthetic mRNA molecule that's going to then produce a protein in your body by getting inside your cells and then using all the cellular machinery to make whatever protein it would be, whether that's the spike protein from the coronavirus, the glycoprotein from HIV, or some protein that might be useful to fight a tumor. Maybe it's a tumor-produced protein that your lung cancer tumor produces. That was the idea. And it was hard because mRNA gets degraded very quickly, so it took some time to be able to modify it, to make it synthetic enough that it wouldn't be degraded very quickly. But what it does is it turns your cells into vaccine manufacturing factories. That the factory isn't, the Swiftwater plant of Sanofi Pasteur in Pennsylvania, it's your cell. You get that mRNA into your cell, it starts pumping out that protein, your immune system recognizes it. So this is something very elegant because all you really need is the sequence of whatever protein you want to do. And because sequencing technology has really become commonplace now, you can sequence anything, a bacteria, a virus, whatever it could be, basically overnight. All you need to know is what protein do I need to generate a response against? And that's why it took hours for BioNTech to be able to come up with an idea, because we'd already done work and knew that for coronaviruses, spike proteins were important. So they said, let's just get the spike protein and do it. So that's why this is going to change the whole field of emerging infectious disease. It doesn't mean mRNA vaccines can be used for everything. There may be pathogens where it doesn't work as well. But the whole concept of plugging and playing, just being able to print it out, basically, that's what's going to make infectious diseases of the future something that are not as much of a threat. And I think that we're going to hopefully see a golden age of vaccinology again, like we saw that golden age of vaccinology back in the time of Louis Pasteur and Robert Koch, where they found a virus or found a bacteria, they made a vaccine, it was done. I think we're going to hopefully get back there again, and there's going to be many things that you can't even really envision where all of this will go. Not just with mRNA, even Johnson & Johnson's technology. That's also a different type of vaccine platform. All of that's going to flourish, and I think that's one of the silver linings of this pandemic is these platform technologies that were kind of languishing and not really getting much interest have now gotten such interest.
Yeah, can you explain how to interpret the latest peak in hospitalizations as contrasted with the prior peak? And the reason I ask this is my doctor was hospitalized a couple weeks ago with COVID, and the reason wasn't because he had life-threatening symptoms, it was because he was required to be hospitalized in order for them to administer the treatment that they wanted to give.
So why are hospitalizations spiking right now? It's a couple of things. We've got a swath of the population that doesn't have immunity, vaccine-induced or natural, and some of those individuals are at high risk for hospitalization. And we've got a more contagious version of the virus, the Delta variant, that's going to find you if you're not immune. And you also have the fact that maybe the Delta variant there's some, at least anecdotal data, that maybe it makes you more likely to get infected, more likely to get hospitalized. And then lastly, you have many people back out into their life again. Even if they're doing it timidly, they're venturing out now because there's vaccines, because they've kind of gotten tired of this. So that all of that conglomerates together and is increasing the hospitalization rate. I don't know what specific treatment you're talking about that needed to be administered to him as a hospitalized patient. You hospitalize a patient when they need oxygen, usually. The monoclonal antibodies, those are outpatient treatments. The inpatient treatments are reserved for sicker patients. So I can't really speak directly to your anecdote of why that patient was hospitalized or why he needed to be hospitalized. But we only hospitalize people, especially in this era, when they need to be hospitalized for COVID-19. So I think that really what we're seeing is a phenomenon of people without immunity who have high-risk conditions for hospitalizations out there in the world getting infected with a more contagious variant, and that's what's happening, because the hospitalization every place has an uptick in hospitalizations, but the problems are very regional. I think it's 8 states represent 51% of all hospitalizations in the United States, basically a band from Texas to Georgia across the southern United States.
Amish, we need to take 2 questions online now.
Question from Robert. What is the current risk for hospitalization or death for unvaccinated children aged 11 and younger? And if the virus is going to find you if you are unvaccinated, what's the purpose of wearing masks for young children?
So this is a controversial topic. So the answer to the first question, what's the risk of hospitalization or death less than 11? It's close to 0. This is a disease that has thankfully spared children from severe consequences. It doesn't mean it's 0, but it means it's very close to 0. And it is lower than what it would be for influenza, lower than what it would be for RSV. I think what we have is a risk tolerance problem in the United States when it comes to children, because even if you tell people that this is, would you do this for flu? Would you do this for RSV? That's a risk that they've already baked into their own calculations. So this is a new risk. So they're going to take it they're going to treat it differently. I think in this country, we're going to treat, I think that's not, children are going to be considered a major special population when it comes to COVID, and it's going to make it difficult for schools, difficult for activities until the vaccine is approved for everybody above the age of 6 months. In other places, in Europe and in other countries, it's probably not going to have that same value. But I think that for children in the United States, this is their ticket back to their normal life, and it's a safe and effective vaccine. So why not get it? But do I think it changes the trajectory of the pandemic? Do I think it impinges on hospital capacity? Do I think this is a serious disease in children? For the most part, it isn't.
Stephanie, you said the vaccine situation will be different next time. What effect will the attacks on the pharmaceutical companies, i.e. post-vaccine delivery, have next time?
They could have this is a big wild card, and I cut this out of the talk, and I know Adam Mossoff's probably in the crowd, but he and I did a panel with Greg Salmieri on the TRIPS waiver, the intellectual property protection. That's the big wild card. If we don't protect intellectual property rights of companies like Pfizer and Merck and Moderna, we're not going to have these products in the future. When it comes to emerging infectious diseases, as I said, companies don't want to invest in vaccines. That's why we have had tetanus vaccine shortages in the past or flu vaccine shortages. It's not a moneymaker for them, especially when you couple that to the fact that you're talking about emerging infectious diseases where there's not a really defined market. You don't know if it's going to actually happen. If they don't have intellectual property, they're not going to invest here. So I do think that that attack on pharmaceutical companies has to be stopped. And I got a lot of hate mail there after I defended the pharmaceutical companies' right to their intellectual property. And I think that's going to be really important. But I do think that there is just this idea that these vaccines came from nowhere, that they weren't produced, that there weren't scientists at BioNTech, that there weren't scientists at Moderna or J&J or wherever it might be, that the goods are just there. And I think we have to fight back against that because all of the technology is contingent on the fact that people see value in actually making those vaccines for people. Because those companies can work on Alzheimer's treatments or heart disease treatments. They don't have to do this. So I do think that we have to be we have to defend those pharmaceutical companies for what they've done. Because I don't think we would be sitting here having this conversation if Pfizer and Moderna hadn't actually engaged. And I think it's really, really important to get that straight, that the innovation that made this necessary isn't something that we can take for granted. And those attacks on pharmaceutical companies, the pharmaceutical companies that gave us our lives back, I think need to be pushed back on really strongly. And I think that this crowd is very good to do that.
Hi, so you talked about the abstinence-only approach and how that was a mistake that was made pretty early on in the pandemic. So this might be related to that, but it seems, and I'm not sure who to blame this on, but there seems to be kind of this idea that everyone's kind of at equal risk of COVID, and there have been surveys that show that young people especially, they very much exaggerate their own risk of hospitalization and death. And there seems to be kind of this denial that it is very much age stratified. So I just wanted to know, kind of what's your take on that? Do you think that's also been a mistake that was made here?
I think in general, what policymakers wanted to do was a one-size-fits-all type of idea. And it is true that the younger you are, the less likely you are to be hospitalized or have severe disease. And I think that was important to say. But it was also true in the pre-vaccine era when high-risk populations were not vaccinated that you could be someone who has a mild case but then set off a chain of transmission and infect somebody that's vulnerable at a nursing home or a grandparent. And that was really happening. And part of the reason that was happening is because we had no way to know whether or not you were infected or not. And I think that whole one-size-fits-all approach came from the fact that we were blind, that we didn't have the ability to test people. If you could say, I'm going to visit grandma today, I'm going to go test myself, that would make it so much easier. Then you could say, okay, if a 20-year-old gets COVID-19 and they don't have any high-risk conditions, they're not obese, diabetic, asthmatic, then I think that's something different. But we had no way to know who they were going to transmit it to or to keep people from starting chains of transmission. So I think that got all muddled into it. But I also think there was a reticence to say, oh, this is that this could be mild in certain individuals. That's the same discussion we're having in children right now, which is very acrimonious. But it is true that COVID-19 has this spectrum of illness, and there are major risk factors for hospitalization that are well established: age and medical comorbidities. And it's not always going to be the case that everybody has that same risk. And I think that there was an idea that we had to do this kind of collectively as a public health problem. And I think that was because we took away all of our precision-guided tools of public health. They were not available. So blunt tools are what were left, and that's what they used.
Okay, thank you.
I've read many articles which say that low levels of vitamin D are strongly correlated with increased rates of hospitalization and mortality. And I wondered why there is no public health campaign to get people to supplement increased vitamin D intake.
There's been a lot of advocacy for that. So vitamin D deficiency is rampant in the United States as people stay indoors, especially probably more when they weren't able to go outdoors. And vitamin D does influence your risk of getting COVID and having severe COVID. There have been some public health campaigns. For example, in the United Kingdom, they mailed vitamin D to people. It just wasn't something that happened so much in the United States, but it is something that I think explains some proportion of the severity and infection. And if we had a vitamin D, I don't think it would have changed the overall trajectory of the pandemic, but it is something important that you could do, that we could have done pre-vaccine, is tell everybody. And there were former CDC director Tom Frieden, who was the CDC director during the Obama administration. He wrote multiple op-eds in the Wall Street Journal, in medical journals, advocating for this approach. It just wasn't something that really took off in terms of the press being interested in it, but some countries did, and I've always advocated that people should supplement vitamin D if they're deficient. No, vitamin D is the one. I mean, if you have a replete diet, somebody asked any other supplements, there's no other supplement that's been shown to have any major impact on COVID risk. Obviously, if you're malnourished, you're going to have lots of different deficiencies, and you should not be malnourished. But for someone who eats an average, Western diet or industrial country diet, I don't think that anything other than vitamin D probably has any evidence.
Thanks for a great talk. I had a two-part question, partly on vaccines. And first, the vaccine approval process, the emergency use authorization versus full approval. In your view, what would be the best system for doing vaccine approval, and who should be doing it? And the second part is, I live in Seattle, so the Seattle flu study was very acute in my mind. And it was kind of amazing to me in the early stages of the pandemic and when the vaccines arrived that there was a lot of vaccines there that were just sitting there because it was a phased approach to distribution. So I was chomping at the bit to go get a vaccine and I couldn't do it. And it seemed logical to me that you would get as many vaccines as you can and many arms as possible as fast as you can because you're racing against time. So I'm just curious of your thought about those two.
So a clarification on your first question. In the current system or like in an ideal world?
Let's do it in an ideal world.
Because so that's a little bit hard, because I think that there you probably would have insurance companies, you would have pharmaceutical companies, and you would have standard organizations that would be giving their stamp of approval to that type of a vaccine based on a very similar process, almost identical in many ways to what the type of data that the FDA evaluates, but it would be done privately, and then insurance companies would make a decision whether or not to use it or not. And I mean, that sometimes happens now, even because the FDA approved that new Alzheimer's drug, but many insurance companies won't cover it. They don't think the data is strong enough. So that's kind of what I would look at. Okay. And the second question was about, so the vaccine distribution. So we prioritized it because we were trying to decant hospitals. We were trying to not have hospitals going into crisis. So that's why priority group 1A was nursing homes. But I think that the prioritization grouping was correct. It was just the execution in the early days was really bad, and they were in this position where so many people were afraid to put a vaccine into someone's arm that, God forbid, was a priority 1B or a 1C or maybe even a 2, that they wouldn't let that happen. And so they made the bureaucracy be an obstacle to getting vaccines into arms. And that's why I was advocating, if you got vaccines left over, order a pizza and just vaccinate the pizza guy. That's what you should have done. I mean, we didn't want people jumping line in the original part, but we didn't want a vaccine in anyone's arm is much better than a vaccine in a trash can. And we did put vaccines in trash cans. We couldn't even, the FDA wouldn't even approve 6 doses out of a Pfizer vial when there was too much in. They had to, and then when they said, okay, yes, we're going to approve it, then they send the wrong syringe, these low dead volume syringes, so they couldn't even get that 6 dose out. But in those early days, it was very scary that we were going to foul this up, and we started to foul it up, but then I think we got our stride.
Thank you.
So I've heard a number of people propose sort of getting rid of the efficacy phase of FDA trials. One, do you think that is like politically viable at all? And two, would that have really helped with, like, say, getting testing out or getting the vaccines out earlier? Is that a...
I think that, so people who say that, I think it's interesting because safety and efficacy have to be balanced, because anytime you give a drug, the efficacy is balanced against the safety. What is the risk of the disease? What is the benefit of the drug? What is the risk of the drug? So it's very hard to separate efficacy and safety for many things. There's certain substances where you can say, yes, of course they're safe. We've got tons of data that you don't necessarily have to think about the efficacy part of it. But when it's something where you're worried about, does this have some side effects and you have to balance it against the efficacy, that becomes difficult. So the FDA initially did just approve safety, then they switched it to safety and efficacy with the CAFAVR amendments, I think during the Kennedy administration or somewhere around there. They changed it. And I think that this is a hard debate to have, because it is true that you're always balancing safety and efficacy when you're prescribing a drug to somebody as a doctor. And I do think that there's a lot of room for the FDA, if we're talking about the current system, the FDA to be much better with looking at safety and efficacy in a way that doesn't preclude things from coming onto the market, to have pathways to get these drugs to people. But it's a very hard thing to do because they are so intertwined, unless you're talking about some kind of innocuous substance or some substance that everybody takes every day, because that's sort of how you decide the risk-benefit ratio. So that's the problem I have with it. I think there's got to be a solution, but I don't know exactly what it is off the top of my head.
Thank you.
Thank you, doctor, for the talk. I was wondering, preparing for a next pandemic, how to open the minds of people, especially dogmatized people that live in evasion. And I was wondering, what is your take on psilocybin in fungi or DMT as molecules and chemicals that have these experiences that in their studies prove that people are willing to abandon, for example, religion or some collectivist mentality of big groups, and instead having a more individualistic approach about taking care of their immune system with good health practices that we didn't see through the pandemic. I didn't see politicians telling people, eat better, go out, do exercise, and at the end, I think that it is our immune system, our best fight against any disease, more than whatever politician is doing. So I wanted to know your medical opinion on it. Thank you.
So so for people who know psilocybin, this is LSD, psychoactive compounds to open people's minds. That part I'm going to not necessarily, I don't have anything specific to say about that part, but I do think that how healthy a country is in terms of comorbidities, obesity, diabetes, play a major role. The United States got hit hard because the majority of Americans are overweight. 6% of the population has diabetes. And countries like Africa were initially spared because they have a much healthier population in terms of those comorbid conditions. So the healthier you are, the more resilient you're going to be. And I think it's part of it. It's just hard to change behavior. We can't get, people still smoke cigarettes. People do lots of things that are bad. And that's very hard for people. We're not a very healthy country in general when it comes to those chronic diseases. And I think that it is part of the discussion, because some of the most hardest hit areas in New York City in the first wave were those places with the highest levels of obesity and diabetes. That wasn't a coincidence. And I think that is something that will make us more resilient. And it is something that needs more discussion. I don't know that there's much, it's very hard to do though, because it's a behavioral change, and that's much harder for anybody. And a politician surely isn't going to change behavior. This is something that primary care doctors have to do, and people themselves have to decide to do.
Thank you.
You spoke of the role that tests and short-term interests of politicians played in shaping the government's response to the pandemic. But the government's policy is not deterministically shaped by tests and short-term interests. Rather, it's determined by people's view of what the government should do, i.e. by their political philosophy. And I do think it gets deeper in this context than medicine or even the epistemology of medicine, because in this case, medicine has only been used in application of a political philosophy. That is, before one asks what is the most scientifically effective way by which the government should manage risks, one should ask whether the government should manage risks in the first place. So I have a question about political philosophy. You talked about the fact that one doesn't have a right to infect other people, and to the extent that it means that if somebody knows that he has a deadly disease, it's not his right to kiss random people in the street. I think everyone in this room would agree. But I think there is a completely different way in which one could interpret this assertion, which is that the government has a role in managing the natural spread of a disease by people who don't know that they have contracted it, and to manage the collective statistics of the disease rather than just specific individual who kiss random people on the street. So do you think the government has a role in trying to reduce death statistics, for example? And why is that different? Why is it any different from reducing deaths from, let's say, hurricanes?
From what? From
hurricanes, like natural disasters in general.
Well, so in the United States, the government does have a role in both of those, but do I think it's a correct role? I think the issue is that if you are a demonstrable risk to other people, if you know you're infected or it can be proven that you are infected, or you've gotten guidance to know that this is a virus that's out there spreading, you might have symptoms and you need to be mindful of that, you need to test yourself if that was available, I do think that the government should be stopping those people, even if they don't know that they have it, if they can be proven to be a threat. I think it shouldn't, and this should all be codified in law. It shouldn't be something that we're doing on the whim trying to figure out what the policy is. It should be, if you've got a communicable disease of X amount of severity and you knowingly or unknowingly spread it, that's not okay. That there's going to be repercussions for that, whether that's that you get put in isolation, you get put in quarantine, or you get sent to an island like Typhoid Mary did. I think you have to actually codify what's going on based on the risk that you pose to other people. And I think the problem was in the United States was that there was no way to know who was at risk and who was infected because we had no tests, because the government actually made it very, very difficult to get tested. So you've got a cascading problem here. Ideally, you'd be able to test yourself and know, and then if you were found to be somebody that had this infection and you were at risk for this infection or have been exposed to this infection, then I think that there is a role for government.
Thank you.
Greetings. Thank you very much for your presentation. It's been very enlightening. I have some stuff that I can't even talk about, but I can discuss this. I recently read through the warning letters from the FDA going over the last few months, the ones that are blocking COVID techniques, COVID treatment, and I've become aware that this is stoking a rebellion against the medical profession and the FDA, including that's one of the drivers of the alternative treatments, such as, for instance, ivermectin, which doesn't work, or HCQ, which is doubtful, as well as other ones. What help or harm has the FDA done in stoking this response in terms of that approach, and how helpful or harmful has this been to your work and the practice of medicine?
So the FDA is a political organization. It's always a political organization, but this took on new heights. So during the Trump administration, they issued an emergency use authorization for hydroxychloroquine, despite any evidence, despite everyone telling them that there was no evidence to do that. And then you had the Democrats who were not in power criticizing the FDA for being politicized and allowing Trump to weigh in. The same thing happened with convalescent plasma. Trump called the FDA director at that time, asked him to approve convalescent plasma, and it was approved. So there was a lot of doubt on what was going on at the FDA at that time. So now when the FDA is saying, ivermectin, you're not a cow, you're not a dog, they have that campaign they just put out. Don't take veterinary ivermectin. No one wants, now they say this is the same organization that the Democrats were criticizing for being politicized. Now they're saying this, so who do we believe? So it has been massively detrimental. This is that breach I'm telling you about, that the politics got so injected into all of these agencies that no one knows what to believe. And and it becomes impossible to really get through to people, except for on a one-to-one basis. I do much better on a one-to-one basis than when I'm up here or when I'm on television, with trying to convince people about something's benefit or something's harm. But it's something we're going to pay for, because it's not. I mean, this is the problem when you have politics injected into medicine, when you have these organizations like the FDA that the president has major influence over. They're not independent, and they're subject to influence. And then when they make influence one way or the other way, you don't know. Is it because of political pressure, or is it because they've actually come to a solid conclusion? And I think that this is another problem with this pandemic that's going to be irreparable.
I'm good. Thank you. Thank you for being a voice of reason, a very public voice of reason, and throughout this, very, very much appreciated. It's been very helpful for me. And in relation to that, you alluded to, toward the end of your talk, the fact that maybe policymakers are starting to listen to a more rational approach. Would you elaborate on that? And are you hopeful for the future?
I am hopeful, because I think that many people didn't think a pandemic could do what it did. They thought 2009 H1N1, that's as bad as it can get in the United States. So they thought it was an afterthought, but they all saw what happened. And I think that the trillions of dollars of economic losses, as well as the hundreds of thousands of lives, I think have really got them to see how badly prepared we were, to see the Taggart Tunnel back and forth over and over again. They actually, I think, get that. So there are efforts underway to get rid of the bureaucracy, get rid of the red tape that's made it hard to develop things. So for example, this is all within the current context. It's not an ideal world. So we have the NIH, we've got all of these organizations. When there's an outbreak, so when there's a Zika outbreak and they needed to do something, they needed to make diagnostic tests or do something, they actually can't do that until they get an appropriation from Congress that says, this is for Zika funding. Because if it's for flu funding, it can't go for Zika. So there's all of that's made it very hard to be proactive. That's going to change. I think now you're going to see the government really being cognizant of the fact that there's all these threats out there, and that it can't be kind of siloed funding that these organizations that are putting out the funding to the researchers, because like it or not, the NIH funds most basic research, a lot of the basic research. Other organizations in HHS fund advanced development of drugs, but they're not going to be handcuffed anymore. They're going to be able to do this more proactive. They're going to be able to, I keep using the word proactive because it's the exact opposite of what happened, but they're going to be able to plan in advance. They're going to be able to start moving products ahead of schedule that might be used or might not be used, but they're going to have more of a Defense Department footing for some of these pandemic threats, for some of the bioterrorist threats. But they're definitely listening, and they definitely want to get it right. And I think the other issue is, at-home tests. I'm working a lot on trying to just make that the paradigm, and that's not any money. That's just actually getting the regulations out of the way so that you can have a toaster, you can have a microwave, and you can have a little diagnostic box in your kitchen and test yourself for everything. Because not only will you be able, it'll help us know what's circulating, but then you won't go to the urgent care and ask for an antibiotic that you don't need. Lots of good stuff will come from that. And you'll get to know all these little viruses. That's actually going to probably happen. So I am hopeful. It's hard, and right now that we're trying to strike when the iron is hot there, because they're listening, and I think that no one wants this to ever happen again. And I think they themselves finally saw it with their own eyes, but hopefully it turns out better.
Thank you. Last question.
So the private community, Pfizer, Moderna, and Johnson & Johnson, was able to create these incredible vaccines. What were the good policies that allowed this to happen that we should be working on protecting? And what are the bad policies and bad regulations that, inventions that could have happened that we don't even see? Or could these technologies have happened earlier if there were certain regulations that were not in place?
I mean, so the answer to the second part of the question is, like, there's almost all of those regulations could have hindered in some way or another what happened. What occurred was this was a national emergency, and they got out of the way, and they actually said, just make the vaccine. We're going to buy it whether it works or not with taxpayer money for many of those Operation Warp Speed candidates. And they gave them logistics. They gave them places to make these things. So, for example, Moderna was a small company. They didn't have their own manufacturing capacity. They found manufacturing capacity for them. They basically did all the logistics. The Department of Defense and General Perna did all of that for them. So it wasn't necessarily like something that you could replicate with everything. It was just, this was a national emergency, like a Manhattan Project for a vaccine. And that's basically what happened. But you can replicate parts of it for the future. And I think we're trying to figure out a way to do that. How to keep the best elements of Operation Warp Speed, to think proactively, to remove all of the regulatory roadblocks, to get things done very quickly. I think the emergency use authorization pathway worked really, really well, even though the anti-vaccine group has kind of exploited it for their own benefits. All of that, I think, is working, and I think likely will be part of the framework moving forward. The question is, can we make this something that lasts for a long time? And the only way that that's going to happen is if it gets codified in law, if it's legislation. And there is legislation for the emergency use authorization. That was in the Pandemics and All Hazards Preparedness Act that President W. Bush signed. So I think there is a glimmer of hope that this pandemic is going to be an opportunity and a catalyst for reform. So those of you who are working in that field, I think people are listening to these ideas now, people that don't usually listen, because they saw. Well, thank you again for your attention.
Thanks for watching. Be sure to subscribe and ring the bell to never miss a video.